So once again, good morning, good afternoon, good evening. Let me just start my video. I am Charlotte Bu from the Geneva Learning Foundation, and it's a pleasure for me to just be here today also as a host, but invited by the Pakistani and the Nigerian country groups to moderate this session. So if we are here today, it's for the inter-country rapid learning on COVID-19 vaccine introduction. And we are hosted today by the Pakistani Scholar Country Group. They invited their peers from Nigeria and from Pakistan to come and learn from their experience of COVID-19 vaccine introduction, because it is it's one of a kind and the very first time in history. So there are quite a number of experiences to be shared, lessons learned, success stories, why not challenges, so that putting their heads together, they could come up with solutions on how to better address the issues and ensure that all those targeted for vaccination are actually reached. So I want to just invite you, if you're joining the room, please go ahead, type in your city, your country in the chat so we know exactly where you're joining us from. So I want to say hello to Mohammed Imran Otaru, that's joining from Nigeria, Rabiu Fage from Bauchi in Nigeria. So I want to especially greet Sfundo, Gratitude, that is joining us from South Africa, Johannesburg. So we are so great to have you join us today, Gratitude. So without much ado, I just want to give us a rundown of how this session is going to look like. First and foremost, we are going to turn towards our host, that is the country team leader for Pakistan, Dr. Mohammed Imran Qureshi, for a word of welcome and a brief intro, just telling us about the Pakistani team. And then we are going to turn towards I would like him to also invite and introduce the person that is the Deputy National Program Manager for Immunization in Pakistan, who will be telling us about the COVID-19 vaccine introduction over there. And so it will also be an opportunity for us to listen at during the session to some of the other members in the panel from Pakistan as well as Nigeria. So right away, I'll turn towards Mohammed Imran Qureshi. Dear Mohammed, please go ahead and unmute yourself and give us your word of welcome.
Thank you very much, Charlotte. And thanks to the Geneva Learning Foundation. It's very much an excited moment to talk to the worthy and talented scholars from Nigeria and Pakistan, and a lot of scholars who are listening around the world. So a warm welcome and good afternoon, good evening, and good night to everyone, whatever the time zone as far as your country is concerned. So warm welcome from Pakistan Scholar Team. So in Pakistan Scholar Team, the people are very dynamic, motivated, and very much excited for this session. They are regularly meeting on every week. A lot of people who have successfully completed their scholar courses, and a lot of people are there who are wishing to start the journey of scholar courses under the platform of the Geneva Learning Foundation. So today in this session, I'm privileged to have with us Dr. Sophia Yunus. She is a talented lady, and she is heading the Federal EPI Pakistan as Deputy Program Manager, and she will be sharing with us the COVID-19 vaccination experience sharing from Pakistan. Pakistan is the 5th largest populous country of the world and most dynamic country, having 4 seasons. And it's just a wonderful land to live over here, peaceful and secure land. And it's just an excited moment once again to host this session and share the experience. So we will be listening success stories from both the countries, first from Pakistan and obviously in the next upcoming week from Nigeria. So I would say warm welcome once again to all the scholars from Nigeria and rest of the countries who have joined us in this session. Over to you, Charlotte.
So thank you very much. Thank you very much, Mohammed, for that word of welcome and introductory statement. I would just want to invite you, if you're just joining us, warm welcome to you. And initially, we had planned to broadcast this session live, but due to technical issues, we are not able to do so. But we have made available the link and access to the Zoom room for all others who desire to join the event. So please go ahead. I've just shared the link here in the chat. If you can share it with friends and colleagues who like to join, inviting them. There is a full capacity to host as many people as possible in the Zoom room right now. So without much ado, I would like to invite Dr. Sophia Yunus. Doctor, please go ahead and unmute yourself and share with us. If you can go ahead and share your screen and present us the situation of COVID-19 vaccine introduction in Pakistan. And I'd like to invite you, dear peers, while the presentation is going on, feel free to raise your hand if you have any questions, type in your questions in the chat or in the Q&A, and also vote for the question that you would like to see answered, so that when the time is right, we are going to read out the questions to our panelists and they will respond to them. Okay, thank you very much, and over to you, Dr. Sophia Yunus.
Thank you, Charlotte. Thank you, Reda. And thank you, dear colleagues. Good evening from Pakistan, and a very warm welcome for this Peer Hub meeting. And I'm looking forward to great discussion. And let me start by saying that EPI Pakistan is, striving hard not only to increase the vaccine uptake in the country and to enhance the, the supply chain management across Pakistan, but also, we are supporting immunization supply chain management for COVID-19 vaccine. And today my presentation will be focusing on a little bit of country profile, because from where we are, and then how EPI program has progressed over the years, and then how we actually developed and strengthened our existing capacities in order to combat when the pandemic was there, and the current situation that we are facing in Pakistan, and also coming to the vaccination process, that how we started on building on the existing resources and then strengthening our current supply chain system. Then the COVAX support that has come into the country, and also the challenges which we faced while, vaccine rollout. And in the end, I will be sharing certain lessons learned that may be helpful for different countries to, learn while they are also in the same phase. So with this, you see this, these are not Geneva or Switzerland landscape. This is from Pakistan, and you can see that how beautiful are northern areas where there are a lot of mountains, and then we have plain areas also. So Pakistan is a beautiful country, and as Imran already mentioned, it is fifth populous country, while the area is also quite large, with around 800,000 square kilometers, with 4 big provinces. And the northern area, we have Azad Jammu and Kashmir, and then Gilgit-Baltistan. And we are, with our neighbors, India, China, Afghanistan, and Iran, along with Arabian Sea. So, EPI Pakistan was started in 1978, and the aim is to, reduce morbidity and mortality across the country, with polio eradication still on the top agenda of the country, with measles elimination and maternal neonatal tetanus elimination are among the objectives which we are striving to achieve. And then besides this, all the other VPDs that come along are to be eliminated. Then the service delivery is mainly taking place through our, fixed sites that are mainly constituted at the health facility level. Then we also conduct the outreach vaccination services, in which the vaccinator goes near to the community and sits in the health house or certain other localities, and the community is brought near to those outreach sessions. And then there are mobile vaccination services also happening, where the vaccinator cannot come back on the same day, so he has to stay there. So these mobile vaccination services are also taking place. With this background, You see, over the past years, as I mentioned, that it started with 6 antigens, and over the long period of time, it has included and it has reached to 11 antigens. And recently, we have introduced the second dose of IPV in order to achieve, in order to eradicate polio. And recently, we are in a process of introduction of typhoid vaccine. It is a phased introduction. And from Monday, we are starting with our campaign in remaining districts of Punjab. So the program is mainly comprising of 7 visits, and in the whole of the country, there are 6 visits, but the largest province in Punjab has 7 visits. And it is the last visit is for a DPT booster, but you can see at birth, 6 weeks, 10 weeks, 14 weeks, 9 months, and 15 months. This schedule is being observed across Pakistan. And as we see, we are also focusing on new vaccine introductions, and hepatitis B was a part of, pentavalent in our country, but very recently we are about to start hepatitis B birth dose also. It was intermittently started in various teaching hospitals, but not a continuous supply was there in the country. However, Punjab has taken a step ahead, and they are starting birth dose of hepatitis B also. From 1st of June, it has already started. And then, different boosters are being added to this schedule, and a pneumococcal vaccine from 10 to 13 we have already shifted. So if you see that the pandemic was affected, our country was affected with the aftermath of detection of the case, when it was first index case was notified on in the month of February. Followed by that, we had a countrywide lockdown, because at that time no one was knowing how we could prevent our community from acquiring, preventing them from acquiring this virus. In this regard, all the immunization services were halted. But at the same time, within 2 weeks, we realized that children are being born, and they need to be vaccinated with essential vaccines, and if they are not given their due right, so we are definitely going to suffer. So in this regard, immediately we developed IPC guidelines, and we developed SOPs, different we started our fixed sites with observance of SOPs, and vaccination started immediately towards the end of towards the mid of April. And then in May, we started outreach activities also. But in June, we planned enhanced outreach, in which, we covered those areas where we were expecting more of a backlog. So in this regard, we enhanced our, routine vaccine uptake with the provision of PPEs, and, with the joining our hands with various stakeholders, be it WHO, UNICEF, and expanded partners also. And ultimately, we were able to, cover most of the backlog. And in the meanwhile, we had joint reviews. We reiterated our commitment to combat not only the pandemic, but also, we started working on covering the children who missed their essential vaccines. And in this regard, our top management was also included. And then we held a NETAG meeting that guided us in order to move forward with covering the children. And the Pakistan Pediatric Association was involved, and, building synergies among various stakeholders, we were able to cover and, most of the backlog of children. Then, our National Command and Control Center, this was a unique idea because the military and, government leadership was joining hands together, and they collectively, met together, and they were engaged in decision-making, policy, and main decision-making was in the government's hand. But while it comes to implementation of various strategies and the policies that the government made, the armed forces, they come up with a very helping hand. So in this regard, wherever the information was lacking from the field, we were supported with different partners and different organizations. And this NCOC helped us in the government a lot in implementing of SOPs wherever people were not following them. So this was a main synergistic effort that was articulated as a unified national effort in the COVID-19 response. So, EPI was designated as an organization to manage the immunization supply chain system throughout the country whenever vaccine was to be available. So it started, I think, in July 2020, when we wrote a letter to Gavi COVAX facility for considering Pakistan and including whenever the COVAX vaccines would be available. And all the correspondence was done by EPI, and the ministry gave us a full and free hand to communicate on behalf of them. And the priority population was identified. First of all, priority was given to the healthcare worker, that whenever an effective vaccine would be available, so healthcare workers will be prioritized, followed by those who are having comorbidities and who are suffering from various illnesses like chronic comorbidities. So they will also be prioritized. And finally, all the eligible age group would be prioritized without, discriminating any of the populations, like those living in hard to reach areas, the refugee population, because Pakistan is hosting a lot of around 1.4 million of refugees that are registered, and a number of refugees that have not been registered with the government. So with an equity lens, we developed our policy, and a national deployment and vaccination plan was developed. And so the aim is that out of our total population of 234 million, we have almost 112 million of population that would be needing vaccination. Initially, it was 78 million because we were excluding pregnant women and lactating women, as the vaccines were not tested in those. But now, as more and more vaccines are available and their safety has been determined, so now we are including all. And the government has set a target of vaccinating 70% of its population by end of this year. So, as you can see, that Pakistan is a country where, the COVID load was also there, but it was not very high as compared to certain other neighboring and European as well as American area. However, still in the region, we were having a number of cases, but the third wave, unfortunately affected Pakistan very badly. First wave, we were able to come out of it, with the grace of Allah. However, the second wave was also managed well, but the third wave was expanding to a larger, area, as well as number of deaths was also higher. So you can see that 4 variants have been detected in Pakistan so far, and still we are facing a number of challenges as we are moving forward with, there are certain smart lockdowns still continuing. And you can see that this third wave, as I was mentioning, it affected the country badly. Now we have a reduction of cases, and today's positivity rate was around 3.5%. And you can see the hospitalization rate was also increased. The people on ventilators as well as high flow oxygen was also quite high. And as you can see that this was since this pandemic has adversely affected the mega cities, so Pakistan was not an exception, and multiple cities were affected badly. So these are the main 15 cities where the brunt of the disease was maximum. And here you can see that number of provinces and their healthcare workers that were affected with the pandemic. Similarly, this is the current situation in which the occupancy of public and private sector has been demonstrated, and how did we conduct the test. And mainly it was from the public sector, but also private sector came hand in hand to support the country. And you can see that, if we see the analysis of all the deaths that have taken place, so our mortality is slightly higher than what is the global trend, and it is predominantly affected among the males as across the globe. And age, median age in which this disease was prevalent was around 62 years. and 73% of them were mainly having comorbidities. So our plan for vaccination was evolved around those who were affected much. So mainly these were the hospital deaths, but some of the individuals, around 10%, were they died at home as well. So now if we see the provincial distribution of deaths, it is mainly, you can see, in 48% is in Punjab, followed by Sindh, and then KP. And as far as the population is concerned, so the similar trends are seen among the deaths as well. The hospitalization rate you can see, and also people who were on ventilator, then age and gender distribution as far as the cases were concerned, and also the deaths as they were concerned. So it was predominantly affecting the males as compared to females. Now, the case fatality rate was also, you can well imagine that it was highest in 80 and above. And then as we go down the age bracket, it was reduced. And in the third wave, we also witnessed a number of children who were affected. So as from the NCOC platform, the National Command and Operation Platform, a number of activities were coordinated. So there were a number of expert committees that were established, and all of them were led by the government officials. And we as EPI developed all the drafts of guidelines, and then they were vetted by the highest management of the ministry, the DG office. And then once they were finalized, they were distributed via the NCOC platform for media and all those who needed those guidelines. And the national vaccine deployment plan was developed. And then how these vaccines, when the vaccines were available, so the priority was set, and those who were to receive the vaccines were also propagated through the same channel. And then for the first time, in Pakistan, we were having mainly paper-based record. In one of the provinces, we had apps available also, and different provinces have different app for immunization child registry. But for adult vaccination, it was the first time that we developed National Immunization Management System. And the name immunization came that our national database system that is hosting all the CNIC, the national registration certificates in the country, was given this task to develop this system so that it is linked with the registration process, and whoever comes and gets the vaccine can be verified through their particular ID. And in this regard, the eligibility criteria was inbuilt within the system. They were given various verification code, so that once they came to the counter for vaccination, the vaccinator had to verify that, okay, because in the beginning, the vaccines were, specifically for healthcare workers and those with comorbidities. So specific IDs helped them to identify, and through the confirmation messages, they were able to get the vaccines from the vaccination counter. And in this regard, the vaccine supply chain management that was based in EPI, and we developed this COVIM module in which all the logistics were entered whenever the vaccines and their supplies, the syringes, safety boxes arrived into the country. They were entered into this module, and till the end user level, they were supplied in a manner that it was visible across the country. And then as I speak, we have a number of Chinese vaccines that include CanSino Bio, Sinopharm, Sinovac, AstraZeneca, Pfizer, along with, Sputnik 5, which is a Russian vaccine that was also introduced in Pakistan, mainly through the private sector. And these are all the vaccines that have been introduced in government sector. CanSino was also promoted by private sector as well. So as we see the COVID response, so in the health department, all the health facility, they were upgraded as COVID vaccination centers. So in the beginning, we targeted our tertiary care and secondary care hospitals. And but since the main focus was in the mega cities, therefore, the CVC number was limited in the beginning. As the vaccine supplies improved, now every day around 200 vaccination centers are being established. Then mobile vaccination was also started, and today, as I speak, 400,000 vaccinations are being given on the daily basis, and we have crossed the figure of 1 million in Pakistan, and this main vaccination took place from the month of May onwards. Now, if you can see that this is the registration under the names, that you have all the database, and then we have helpline. In the province, we have different helplines, but in national level, we have 1166 helpline where the callers are calling, and there is a team of doctors who are addressing their grievances, and if there are problems in reaching out, and if there are certain complaints, they are also accounted for. Then there is an AFI system also built in, and where the people are reporting through the NIMS system, the COVID system, and also through the 1166 helpline. Now, this is the data that is being collected because in Pakistan from 18 onwards, the vaccination services are open, and there is walk-in free. Anyone can just submit their CNIC number on 1166, and upon receipt of code can just walk into the health facility and get themselves vaccinated. And we are ensuring that we do not have any interruption in vaccine supply, and we are since the month of February, beginning of the February, when we got the first consignment of vaccine, we did not have any stock out of COVID-19 vaccine in Pakistan. So we are strategically managing, and we are opening the age bracket based on the supplies that are available. Now, you can see the journey. So as I mentioned, that it is mainly from the month of May that we took a steep and an upward trend is there as far as the vaccination is concerned. And from 11th July, recently we have opened 18 plus walk-in, and people are getting, their vaccines. There are 24/7 vaccination centers also in the mass vaccination areas where people are coming through drive-through also. So, we started with China. This is a game changer. Pakistan was manufacturing vaccines in the past, but due to a greater demand, we were unable to cope to the country's need. But in recent times, with the support of China, the brotherly country, we are able to formulate a vaccine. And, every month we are expecting the 3 million doses of PakVac will be into the system. And as different vaccines are coming to Pakistan, so Pakistan own a vaccine that is with the support of China. The concentrate is being brought in, and we are formulating the vaccine. So it is also the first lot of it is already in use, and soon we will be getting this 3 million per month from the month of June onwards. So we are, as I mentioned, that we are collecting the AFI data. So up till now, above 8,500 AFI have been recorded, out of which mainly are the minor AFIs, but major AFI have also been reported, and they have been also, we have a National AFI Review Committee that determines the causality assessment and finally responsible for case classification. So you can see COVAX also supported us with the first consignment that was of 1.2 million doses of AstraZeneca. And they were provided with the close collaboration of our allies and, European Union, and there was a great celebration going on. You can see when it came to Pakistan, and so it increased the vaccine mix in Pakistan. So you can see that Pakistan has state-of-the-art national warehouse, where we have also installed ultra cold chain equipment to cater to the needs of certain vaccines that require ultra cold chain and freezing temperatures. So we upgraded our cold chain facility, we upgraded our transportation facility, and we are the state-of-the-art national warehouse and provincial stores are equally vigilant in maintaining and supplying doses, so that the potency of the vaccine is not lost while we are transporting these vaccines. But still, we have challenges that our surveillance and vaccination process is a bit there are challenges in our surveillance system, and tracing, testing, and quarantine facilities were challenged during the early days of pandemic. So whatever workforce was involved or was available in the country was used to manage this. And our healthcare workers were also sensitized, and they started to adopt SOPs. But still, it remained a challenge, and still some of the healthcare workers are still, they are not following the SOPs. And the smart lockdown, when people, tried to break those limitations that were imposed upon. And adequate supply of vaccine remained challenge in the beginning, but now we are having vaccines that are beyond our requirement. Sometimes, 400,000, as I mentioned, we never were stock out, but in the beginning, the demand was also less. But as we have opened all the age brackets, the demand is increasing. In the beginning, vaccine hesitancy was much, but when the media was flooded from information from our neighboring country that, virus was all around. So that was acting as a catalyst, and that removed various myths and misconceptions from the community's mind. And we have seen really flooding of people in our mass vaccination as well as the COVID vaccination centers. And, competing priorities like measles, polio, we happen to report the number of cases, and CVDPV2 was also challenge in Pakistan during the same time. So it remained a challenge. We were planning to conduct typhoid rollout in 2020, but we were unable to do so. And as I mentioned earlier, that we are doing it now when the things are much under control. The non-availability of COVID-19 vaccination infrastructure, we did not plan for such, because we never had adult vaccination counters. They were very limited for those who were traveling abroad, and they were not all across Pakistan, mainly in the mega cities. A few centers were there, but we had to, reinvent the wheel. We had to make guidelines that how these adult vaccination counters should look like and what facilities should be there. So mobilizing the existing resources, we were, challenged initially, but ultimately we overcome. And the human resource constraint has already been there. So EPI is still being overburdened with some of the vaccinators in the mega cities are doing dual job. They are not only serving as adult vaccinators, but also, doing RI vaccination coverage. Then the issue in implementation of COVID-19 SOPs remained a challenge. So, but due to this NCOC platform where Pakistan Army was standing with the side of the government, so they helped us a lot in observing the SOPs. So initially we were thinking that this third wave would be devastating, but as I speak, alhamdulillah, we have managed to overcome through a collaborated effort. And there are gaps in mobilization of the communities for COVID-19 vaccine. We still think that the response is not as overwhelming as we would have expected. And we need to do a lot in mobilizing the community, in building their trust over vaccines. vaccines, and in sharing role models who have been vaccinated, and they will be prevented of seriousness of disease in future. So with this, there are certain lessons learned also. This one platform and one team approach helped us a lot. All the data was triangulated at this national forum, and decisions were made, informed decisions were made collectively. And then if there were violations, they were also reported. Then the management information system, the RMS that was developed, it helped in identifying where are the gaps and how we need to scale up our capacities. Then where are the GPS related technology helped us in identifying areas from where the people are being reported more, so how to do lockdown. And then there were Pak Nigeban app that was giving a real-time visibility where the hospitals are, where there is a bed available, and ventilators are available. So the integrated disease management information system helped us in reporting and making surveillance a bit smooth lined. And then education institutions were also guided in order to adopt SOPs, and this and thanks to them also, sometimes with very short notice we closed the institutions, and then within a short duration time we said that okay, go and start the education system again. And having said that, and national helpline was also constituted. It was basically a polio and EPI helpline that was piggybacked in order to increase its capacity, and it helped a lot. And most of the AFIs we are getting are from the NIMS as well as 1166 helpline. The telehealth portal was also introduced, and it went well as far as the the screening and treatment is concerned. Then Sehat Tahaffuz helpline of 1166 I already mentioned. Then new isolation centers and treatment centers were identified, and they were established, and they are also now offering vaccination services. Then community mobilization was also of essence. Prime Minister Relief Fund, through and linked it with the SARS program and certain other programs that provided cash transfers to the communities that were in dire need of them. Then Ministry of Health also launched a We Care campaign in protecting our frontline workers, in the context of COVID-19. So the Tiger Force was launched. They were mainly to enforce what the government's decisions are on lockdown, and asking people to adopt SOPs. A SARS program was it was the largest program as far as the economic hardship of the community was being shared. And then Yarane Watan, this was a public-private partnership with the Ministry of Health and Pakistanis who were overseas, and human resource development. And then, a network of labs was also established through this, pandemic response. So, number of organizations supported us. World Health Organization is always among the implementing partners in EPI program, also in disease surveillance, and in improving immunization coverage. Same is the case with UNICEF. They are strengthening our immunization supply chain in the country, and also providing community awareness and increasing demand in the country. Bill and Melinda Gates Foundation has always supported polio program, and EPI, our existing program of National Immunization Support Project, is very much supported by the Gates Foundation. And in this difficult time, all the donors and partners, they came forward to supporting, especially what to talk of Gavi, all the grants that were available. Flexibility was given by increasing the time of utility in the country, and also flexibility in diverting the funds towards COVID relief and response. So with this, I thank you. And my colleague, Dr. Imran, if I missed something, please do add. And other colleagues, I'm happy to, take question as well. Thank you.
Thank you so much, Dr. Sophia Yunus, for this wonderful presentation. And looking at the comments in the chat, it just shows, I just really wanted to read this comment from Majid Adisa that says, there is a lot to learn from Pakistan here. Great presentation. So before moving forward, I know if you have, and I want to thank Dr. Mohammed Imran Qureshi and Mohammed Taimur, who have been answering the questions in the Q&A. And if you have any questions, please go ahead and raise your hand. I'll turn towards you and invite you to unmute yourself to ask your questions. But before that, I would like to turn towards team leader for the Nigerian country group, who is here today and who accepted the invitation from the Pakistani team leader to tell us, after listening to, first of all, greet the whole panel and the attendees present, and after listening to this a presentation from Dr. Sophia of Pakistan, what is your takeaway? So over to you, Baraka Tafida Maman.
Oh, wow, thank you very much, Charlotte. Wow, this is great. It gives me great pleasure, to be part of this experience sharing event with scholars and other participants from various parts of the world. Before I continue, please permit me, in the spirit of solidarity, to empathize with our Indian counterparts. They've been facing a lot of challenges from the COVID-19 pandemic. It is hoped that the efforts that they've invested so far to curb the COVID-19 menace will not be in vain. So back to the meat of the matter. This has been a great presentation. Thank you, Dr. Sophia. Thank you also, Dr. Imran Qureshi. As earlier mentioned, I am Baraka Tafida Manman, the team leader for Nigeria. For us as a country team, this is really a monumental period. It's quite a historic event for us. We've been on this for quite some time. There's been a lot of preparations that have been done in the background, for this event. And yeah, thankfully, the day has come. We've listened to the Deputy National Program Manager, EPI Program Manager in Pakistan. That was a wonderful presentation. A lot of information, a lot of experience sharing for us. It is also hoped that with this, would add to what has been done in Nigeria, where we need to add a few points. I also believe that there are a lot of burning questions from the Nigerian team and possibly people from other parts of the world. Some of the questions have already been answered, as I've seen on the Q&A section. So big congratulations to Pakistan. You guys have done a great job. The Nigerian team has also been doing a lot of work. We've been able to co-opt a lot of members who have been working tirelessly to see how this event becomes a success. Well, as time goes on, I'm sure we have a lot of other members who would like to speak and ask a few questions. Once again, thank you, Charlotte. Many thanks to the Geneva Learning Foundation.
Okay, thank you very much, Dr. Baraka Tafida Maman, team leader for Nigeria. Okay, so we'll go straight with the questions. I'd like to invite Dr. Emmanuel Musa from Nigeria. Please unmute yourself. Afterwards, we'll turn towards the hands that are raised. Emmanuel Musa, you asked a question in the chat. So please, can you unmute yourself and ask your question to Dr. Sophia and the rest of the panelists from Pakistan? Emmanuel Musa? If not, I'm going to invite Atai Abubakar. Atai, please go ahead and unmute yourself.
Yeah. Good afternoon, good evening to all. It's a wonderful presentation with very rich that we can learn from Nigeria. To the presentation, there is major EFI reported in Pakistan. Have they categorized them by age group? Thank you.
Yes, thank you so much. Shall I respond or we take all questions?
No, please go ahead, Dr. Sophia.
Okay, so we have, we are doing daily analysis of all the AFIs that are being recorded, and we are also specifying which antigen they have received, which vaccine against which we are getting more of the AFIs. So, age segregation, and then with the gender. So each age bracket we are segregating. So most of the AFI are 50 plus, and because that was the age cohort that was open for vaccination since long. So the denominator is almost, the percentage of AFI is maximum in 50 plus. However, all the age bracket are reporting minimal, mild AFIs as well. So the mild AFI are mainly headache and pain in the arm. However, the major AFI that were reported were also, weakness of the body, and a few of them had MI. So they were treated, and but then when they were further investigated, it was found that there was calcification within the cardiac vessel. So we have investigated, and the age segregation is also there. So the data is very extensive, and we are guiding our decision around more vaccine introduction on the type by which the there are minimal AFIs. Over.
Okay, thank you so much, Dr. Sophia. Please, if you unmute yourself, go ahead and introduce yourself so we know exactly who you are, or where you work and what you do. And remember, we are talking about experiences on COVID-19 vaccine introduction. So it's good that we focus really on the topic at hand. That said, I see a lot of raised hands starting from here on the panel. So I'll go directly to Sambo Ishaku. Please go ahead and unmute yourself. Don't forget to introduce yourself.
Okay, well done, Dr. Sofia Imran. I'm Dr. Sambo Ishaku from Kaduna, Nigeria. I work with World Health Organization. Now, I want to find out, in Pakistan, do you have hard to reach or high risk areas? And do you have specific plans on reaching people in this remote area? That's number one. And number two, you mentioned a lot about the AEFI. Now, do we have sentinel sites for AFI surveillance in Pakistan? And also, we may need to know more about supervision, how the process of vaccination exercise is being supervised, if there is a supervisory plan and how it is being done, and more about the waste management system you have in Pakistan. We want to see to compare with what we have here in Nigeria. Thank you very much.
Thank you. Regarding hard to reach areas, as I mentioned in the beginning, that north of Pakistan is all hard to reach, and we have a system of EPI. So we transported vaccines through the same system, and our health facilities are also there, but they are scattered. And we have an outreach system also inbuilt. So the same system is being taken care of for this COVID-19 vaccine delivery. Besides this, the mobile vaccination, each district, our main load for COVID-19 was in the mega cities. So our stationary centers were there in the big hospitals. Then we, as the more and more vaccines became available, we expanded it through, a number of health facilities that were in far-flung areas. And also mobile vaccination teams have been constituted that are going in those hard-to-reach areas where, regularly we are not reaching with vaccines. Coming to your question on waste management, our system of waste management is already there. So we are following the same mechanism as of routine EPI vaccines, and the incinerator also being used for infectious waste disposal. So the same system that was already there has been piggybacked for COVID-19 vaccine. Definitely the SOPs and segregation of waste as far as the COVID-19 vaccines are concerned, we have to follow those SOPs as well. And then I think there was something regarding AFIs also. So yeah, so the surveillance system, sentinel site surveillance, no, actually we have already passive surveillance as well as active surveillance going on in the country, because we have a number of polio workforce that is still in Pakistan. So from the passive surveillance, mainly we are getting these reports, and the AFI form is being filled at the health facility whenever someone records it and reports to the health facility. And then these reports are being carried out. The health facility focal point is the one who shares this information to the district health teams. And in every district, there is an AFI committee. And this AFI committee then responds to the immediate need of the person who has developed this AFI. And then there is a provincial team also that looks into the details, whether the district has conducted the investigation as deemed necessary. I think I covered most of your points.
Yeah, thank you.
Yeah,
Okay.
there is a question in the chat. Do you have AFI reporting system? So in Pakistan, we already have. And, we have in EPI, we had AFI reporting forms that were available at every health facility in public sector. However, in private sector, we are getting this access through our polio workforce, and we are getting these reports. And from there, every district surveillance officer, and they have been designated as AFI focal person also. They are also collecting all these reports, and we have a zero reporting for AFI also. So the system is there. So the same system is being used for this COVID-19 vaccines.
Okay, thank you very much, Dr. Sophia. I would like to turn towards right now to Chika Ofo. Please go ahead, introduce yourself, or me yourself, introduce yourself and tell us how you are involved in COVID-19 vaccine introduction, and then you can ask your question.
Okay, hello everybody, I hope you can hear me.
Yes, loud and clear.
Okay, my name is Chika Ofo. I'm the founder of an organization called Vaccine Network for Disease Control, a CSO. We work with the states to make sure, create awareness on the value of immunization, and do our best through our approach of adopting communities to make sure that most communities accept vaccines. So we focus more on vaccine acceptance. Okay, my question. This is a very wonderful, wonderful, wonderful presentation. So I just wanted to find out, in your awareness creation strategy, which one was more successful? Was it the internet-based one, or was it the one-on-one? Which one played the best? Which one was more successful? So that's one. And then for my second question, I wanted to find out which of the vaccines, because I see that more than one vaccine was introduced to Pakistan. Which vaccine was more effective? Which one had more AFI, that kind of thing, so that so I wanted to just understand those in those two areas. Thank you very much.
Thank you so much, Chika. And I think it also ties with a question from Munesales in the chat that says, what strategy did you adopt in addressing vaccine hesitancy and misconception? So you could just gather these questions and answer them, Dr. Sophia.
Quickly, also the gender disaggregation. What was the reason? Why were there more men than more women? Did they do any research to find out what caused that as well? Thank you.
Yeah, thank you so much. Dr. Imran, you want to answer?
Please go ahead, then I'll contribute.
Okay, thank you so much. So regarding the method that we adopted for awareness of community, because it was a pandemic, so we could not do most of the social mobilization or interpersonal communication. So electronic media that had never been proven to, increasing reach to the community worked in this regard. So our national electronic media as well as print media were pivotal in creating awareness about the vaccines. and also our social media platforms. Astonishingly, we have a lot of Facebook, Twitter, and WhatsApp users. So all those groups which are headed by the government officials and our partners were flooded with the information, the positive information, and all those myths and misconceptions that were coming through the social media. So the media analytics was working at with the support of UNICEF. Wherever there was a negative comment, it was highlighted at the forum of NCOC, and these people were targeted with the positive information. So we were doing our analysis at that point also, and especially the Indian wave that was flooded in our media, that there are a number of cases increased in the neighboring country. So that also act as a stimulus for our in enhancing our vaccine demand. So it was mainly our traditional media as well as social media. We could not practice much of the interpersonal communication as well as social mobilization activities as far as but whenever there were campaigns, polio campaigns, so when the workers were going house to house, they used to disseminate information regarding vaccination. Then regarding your question on analysis of gender, because in Pakistan, we have more men working as compared to females. So females were more housebound. So men were also meeting, and they were, going outside. And but yes, they were more affected among the community. And regarding further question, I think I missed something. So Imran, can you help me?
Yeah, thank you very much, Dr. Sophia Jonas. First of all, I really want to appreciate and acknowledge the presentations you have given. It is just wonderful. And behind all this success story, the Team Pakistan, I want to appreciate each and every scholar who put real efforts to make this presentation and this event more successful. So thank you in that reasons. So a lot of questions were around regarding the vaccine hesitancy. The Pakistan is unfortunately among the last 2 countries of the world who are still endemic for polio. So along with Afghanistan. But one thing which we are taking as lessons learned from majority of the polio campaigns and a lot of routine immunization campaigns, that the strategy has now evolved, that how we gonna conduct successful campaigns, what challenges could come and how to address them. So probably why Pakistan is doing good. One reason, we are very much mature now in executing campaigns because of this polio challenge. So coming back to vaccine hesitancy, you're right. A lot of myths and misconceptions are around. But once you are very mature in your strategic decisions, you address those myths and challenges. We have enlisted all the myths and challenges and misconceptions, grouped them together, and just looked around the root cause analysis, engaged medical associations, pediatricians, consultants who are responding to the medical related aspects of these myths and misconceptions. Also engaged a lot of religious scholars who are giving religious background and refusals and hesitancy, addressing knowledge and awareness to the public. Same goes for other social sector. But this challenge is huge. I always believe where there are vaccine hesitancy and where there are vaccines refusals, but a lot of people and a huge number of people are there who really want to get vaccine. Unfortunately, we don't discuss for those people who are ready to get vaccine. And we always discuss 1 to 2%, maybe 10% of those people who have certain reluctancy. So in Pakistan, what we actually do, we have both the strategies. We follow for vaccine lovers and just facilitate them for vaccination. And we also address the vaccine hesitancy and areas of refusals. Over.
Thank you very much, Dr. Mohammed Imran Kureichi. There's still so many raised hands. I'll just go directly to Ndayo Iwo. Dr. Ndayo, if you can unmute yourself, please tell us who you are, and then go ahead and ask your question.
Thank you, Charlotte, and thank you, everybody else. I want to appreciate, I am Dr. Iwat. I'm the coordinator of the rollout in the Abuja Federal Capital Territory. And I want to appreciate the Pakistani team. Dr. Sophia, you've done a good job. And I have 3 areas I want you to clarify. Number 1 is still on the social mobilization, the advocacy, communication, and social mobilization. You are also adopting the first introduction of the vaccine. And the first one, as you have just given us now, is about specific people, they are targeted people in this phase. And in social mobilization, I believe that you should have some challenges there, though you have put it that on your box, that there is a challenge there. So I want us to be very clear on this, because this is very important. When you have other people eager to have the vaccine and they are not included in this phase, do you have to turn them back, that they should wait for their turn? Or do you have, and then there may be an overriding reason why somebody should want to have vaccination at that time? Most probably those that are will be traveling abroad, maybe part of the public health requirements for international travels. So those people, if they are not within the target, I believe that you should capture them. So your jingles or your communication modalities should also be able to showcase that, so that people will not turn back and say, oh, if I go out there, I will not be vaccinated. Then 2, the electronic management of immunization data. How do you deal with issues of people that are in diaspora taking the first dose in another country and then due for second dose in Pakistan, and they are in country? Do you have electronic management system for immunization data that can synchronize or harmonize data from the first dose with the second dose that he or she is due for while in your country? Then lastly, from my side, is higher than the global average. That is very important, though the prevalence is low, but you have to note that. So we still have to do more there. And I believe that the other vaccine preventable diseases, as we have observed that the manpower is already stretched and strained, having to deploy those that are supposed to do the RI to this pandemic response. So what are you doing about that? What are you doing about it? Because we can't afford to have local outbreak on top of the pandemic. So thank you, Sophia and Pakistani team. Over and out.
Thank you very much. Let's start. Then I'll request the other colleagues to join in the discussion. As far as your question is concerned regarding the vaccinated clients who have got their first dose and they need to get second dose, and got first dose outside of the country and came back to the country, and now they are waiting for their second dose of the same vaccine. One thing is pretty clear, that in Pakistan, we are managing a wonderful national immunization management system, which is called NIMS. That is basically the electronic immunization registry. And a lot of lessons being learned from this rollout of electronic immunization registry database in the country. You know, the same goes, like if some client is getting first dose from Pakistan and moving outside to any other country. So what we are actually doing, we are maintaining our record within this NIMS as far as the clients are concerned with first dose and the second dose type of vaccine as well. So it is a like categoric decision and strategic policy within the country that the people who got first dose with one type of vaccine will got the second dose with the same type of vaccine. For example, if someone has got Sinopharm as first dose, will definitely get Sinopharm as the second dose. So how we maintain it? We basically maintain it through NIMS. So NIMS maintain the record. So we will see and we will decide if people are coming with and got already some vaccine. Is that vaccine is already available within the country? We obviously go for the second shot after verifying all the documents. And if we have given some client one type of vaccine and they are moving abroad, so we give them certificate of partial vaccination with one dose so that they can go outside and get the second dose of the same vaccine. So coming back to the second question, first of all, I would want to request to all the participants, if they could ask like one question and give more and more opportunity to others, it will make our case easier, and we can also retain the question how to respond and what to respond. Now, I would request Dr. Taimur Kayani to please join the discussion and add few comments from his side.
Thank you very much, sir. And thank you to all the ones who were hearing to us. It's like as Sarah clearly stated, and Dr. Sophia has also indicated, like in Pakistan, we have a national database where all the citizens of Pakistan are registered, and it's called NADRA. Now, NADRA has, established a system which is called NIMS, National Immunization Management System. As soon as the age cohort, when it gets opened, the user, the citizen, they send an SMS to 1166, and they get the code. And with the code and their ID, they go to the COVID vaccination center where they get vaccinated, and their data, it gets reflected in the National Immunization Management System, which is made by the, the National Registration System, NADRA. So all the details are there. Next time, whenever the patient or the citizen is due, they get an SMS that you are due for your second dose and you may visit the CVC. They visit there. And just in case, if the patient or the citizen, they get an FE or something like that, it also, it also gets registered in the NIMS. And if it comes later, they can just simply call on 1166 and they can report that I have been vaccinated on so-and-so center and I've developed this FE. So that is a very, well-maintained system. And other than that, we have another dashboard, which is called COVIM, that is COVID, inventory management system. In that, all the inventory related things, they are registered on daily basis. So NIMS and COVIM, they are collectively, they're compared, and all the discrepancies in the data, they are daily cleaned. So that is a very, very big system which we have here in Pakistan. So there is no chance of any discrepancy there. Thank you very much, and over to Dr. Imran. Thank you.
Okay, thank you. I don't know, Dr. Imran, you wanted to add something?
No, not exactly. If there are other questions, we will love to respond. Thank you.
Yes, definitely. We still have so many hands raised, and I want to say thanks to Dr. Sophia that's also adding some more information in the chat, so you can take a look in the chat for more clarity. So I would like to turn now towards the other attendees in the room. I want to invite Bashir Sharif Mohammed, and just to say the 60 minutes schedule for this session, it's long gone. We are 6 minutes over the time, but I want to crave your indulgence. We still have so many raised hands. So I think if there are many more questions, we have the opportunity to listen to the Pakistani team today. So please go ahead, introduce yourself, and tell us who you are, where you work, and how you are involved in the COVID-19 vaccine introduction. Over to you, Bashir Sharif Mohammed.
Okay. Good afternoon all. Can you hear me?
Yes, we can hear you.
Hello? Can you hear me? Hello? Okay. I'm Dr. Mohammed Bashir Sharif from Kano, Nigeria. I'm working with WHO. I'm part of the COVID-19 vaccine introduction. I'm the state technical assistant in Kano State. I'm actively involved in the COVID-19 vaccination. My question is just a form of clarification, because part of their presentation, they discuss our days vaccine hesitancy. I just want to be updated. What about the health workers? How are they? Did they observe any vaccine hesitancy with regard to the health workers? Especially we are in Kano, we are having such a big issues, and I just want to get an experience from Pakistan. If they have it, how they overcome it with this case of vaccine hesitancy. And secondly, they discuss about the social mobilization. With regard to social mobilization there in Pakistan, do they have any is this that there is not any strong network in overcoming this problem of low social mobilization in Pakistan? Thank you.
Thank you very much, Bashir Sharif. Regarding the first question, knowledge at times is a big problem, and you're right. Once the first cohort healthcare worker, with regards to the risk, they were like open for vaccination in the country. A lot of people have like concerns in their mind regarding the safety of the vaccine. And it's a novel virus, and vaccine development was done in too urgent way that people at times are hard to believe that the vaccine is quite safe and they are ready to go for it. But believe you me, that initially they were like, you're right, there was sort of a reluctancy and hesitancy. Probably they were like thinking that let some people go for vaccination, and we will observe if there are like any adverse events coming, any adverse event of special events coming, and then we will decide that we want to go for vaccination. And if you have provided them with a few number of choices, like at least 5 vaccines we have mentioned which were used in Pakistan, it makes their case easier, because they have gone through various documents, various guidelines from the world, from WHO and from other resources. And they get their mind make up that, okay, the safety index of this vaccine is quite high. It is also gone through under the emergency use licensing from WHO. Let's go for it. So right now, I believe that there is no big reason. But in the start, there were like a few concerns regarding the vaccine safety among the healthcare workers. But now I have saw that all the health workers, they are getting vaccine, and more than 95% of their care workers, they have already got their vaccines. And that is the reason why they are providing the emergency management in the emergencies and in the ICUs free of fear as they were having in the past, because right now they feel they are vaccinated and they are safe. Regarding the social mobilization, as I already told, that we have lessons learned from polio campaigns, and a lot of strategies have already in place. Like if you will call me, you will first listen message on COVID. The people will be asked to follow the standard COVID precautionary measures, and let's go for vaccination and save yourself and your family. Because we believe until unless we are all safe, nobody is safe. So we have to get vaccination for everyone. So a lot of like social mobilization activities are in place, lot of features on electronic media, lot of things on print media and on social media. Because in social media at times it's a problem, because a lot of myths and misconceptions are already there. But the good thing is that those myths and misconceptions are tactfully dealt, and I would say professionally dealt by NCOC, because they have segregated them and they have like grouped them. And as I already said, they engaged the religious scholars, the professionals who are responding to all those myths and misconceptions. That's why the vaccine uptake rate has increased drastically within the country, and we have already crossed 10 million vaccine successfuls in the Pakistan. Over.
Thank you very much, Mohammed Imran. I would like now to invite, I see many other races, and Roger Skani. Please go ahead, very quickly introduce yourself, your involvement in COVID-19 vaccine introduction, and then ask your question.
Okay, thank you, Charlotte. Good evening, everyone. I'm Kani Rogers Bariture. I work with Chai Nigeria team and in Niger State, Mina. I'm deeply involved in the COVID-19 vaccine introduction, especially around logistics and data management as well. So my question, most of my questions, I had about 3 to 4 questions, but I think some have been answered, so I wouldn't go back. First and foremost, I want to applaud the presenters. Very interesting presentation, and for me, we've learned a lot. I've taken some lessons and document them for our use at our state level here. As a follow-up to Chika's question,
where we observe that the country is using different vaccines, unlike in Nigeria, where we are using only Oxford AstraZeneca. Knowing that there is variations among these vaccines, especially around efficacy and dose, how is the country team able to manage this variance in efficacy, knowing that people's physiology differ and tracking AEFI effectively, aligning it with the variation in efficacy and dose, knowing that some of these vaccines require 2 doses, some of these vaccines require 1 dose. So I don't know how, I want to understand how the country really manage this variation in efficacy of the vaccines and dose. I think that's one. Secondly, I had a question around the data management, but I think you've used the names to explain that. But how is the country, knowing that while you were giving the introduction, you showed the geography of Pakistan, there are a lot of hard to reach area, the mountains and the rest. How we're able to utilize this electronic vaccination management data system in hard to reach area where we have network challenges? Are there mechanisms you put in place as an alternative measures? I would like to learn from you, alternative measures when there are network failures and challenges in your electronic management system. I think then the third one is knowing that a lot of resources and logistics have been put in place. Can the country share with us your data management system in resource mobilization and logistic management, knowing that donors are more interested when there are transparency in resource and logistic management? Can we learn from you how you were able to put together tracking daily how resources comes in and how resources are utilized and commodity distribution? Can we learn from you as well? I think those are my 3 questions. Thank you.
Thank you very much, Rogers. First of all, you said since different vaccines are used, so different vaccines have different efficacies. So how we are managing? You know, at times, what was our slogan? That since vaccines are quite safe and they are already gone through the emergency use listing by WHO, since it is not a wish list. So if you grab the opportunity, you are among the cohort which is open for vaccination and you are around the vaccination center and there is a vaccine available. Don't think that you have to choose among various menus and go for it and get the vaccine, whatever is available. That was the stance in the country. And this stance has really helped us. You know, at times these efficacy-based selection and choosing happens among the healthcare workers who have a bit of knowledge. You know, but that part has already covered that it was the first cohort who was opened, and at that time Sinopharm was available. So this was the vaccine which is used by majority of the healthcare workers. Later on, other Chinese and AstraZeneca vaccine were added, and you know, that was like being used over there. Regarding the second part of your question, look, the NIMS and COVIM are the major 2 systems which were used in the country. NIMS is exactly electronic immunization registry and a very beautiful database to record all the vaccinations. And as far as COVIM is concerned, you know, COVIM is basically the inventory management. And it is also wonderfully managed that all the vaccines and required logistics are tracked very easily. So once you are has to receive one consignment, so vouchers will be issued and you have to accept the voucher in the system. Once you accept this, lot is shifted to your stock, and then you have to distribute it to the lower down. And these stocks are then distributed again by using the system. And then it is utilized at the COVID vaccination centers and at the mass vaccination centers. You know, why we manage this internet connectivity challenges? Because at first we opened selected areas as the COVID vaccination centers, and they were the teaching hospitals within the country. Then we added up in the list as the district headquarter hospitals, then Tehsil or town headquarter hospitals, and they were the major COVID vaccination centers. Later on, we realized that we need to just open up the mass vaccination centers. Since all of these things are located within the urban settings, so the connectivity was not a big challenge. So awareness compelled people to come from the far-flung areas, from the remote areas, from mountains, rivers, and to come to the like town hospitals and get their vaccination done. So that was probably the reason. So I would request Dr. Sophia to respond to the third part of the question.
Sir, if I may put in something.
Sure, please.
Thank you very much, sir. Sir, it's like when, to his answer regarding the connectivity and the hard to reach areas in Pakistan, it was like basically we just figure out that we must have three things for any COVID vaccination center. Number one, we must have a cold chain system where we can keep vaccines. Second was that we must be having internet connectivity. And third, like we must have a doctor to manage any untowards FE, whichever surfaces after the vaccination. So for that, like in the northern areas of Pakistan, where we have hard to reach areas, we have like military based connectivity here, internet connectivity, which was enhanced to all the CVCs which we have. And currently we are having 125 COVID vaccination centers in hard to reach areas of Pakistan. And excellently vaccinating all the masses here as well. Thank you.
Okay, thank you so much. Dr. Sophia, please go ahead.
Yeah, just to add what Dr. Imran has said, that the system was enabled with offline entries. So wherever internet connectivity was not there, the vaccinators were able to maintain Excel sheet, and whenever they have time, they will send it to the district, and where within 24 hours they had to submit those entries so that in the morning the database is complete. So this was important. And then we did not give, because the vaccines were limited, so we did not offer the community the choices that, okay, you do your selection. So whenever Sinopharm was available, so whatever vaccine was available, the client was offered that vaccine. And there was a unanimous, a voice from all across that all vaccines are safe. So whatever is coming, in the beginning, as, someone from, I think, Kano asked regarding vaccine hesitancy, how it was tackled in healthcare worker. So initially healthcare workers said, oh, this is a Chinese vaccine, so we will be waiting for COVAX related AstraZeneca when it will be coming to Pakistan. So they wanted others to get vaccinated. So, but then we heard a few, the media was bombarded with some other hesitancies developing in other countries. So then immediately, demand for Chinese vaccines increased in the country. So, but whatever was given was not on the choice of the individual, but whatever was available with the CVC supervisor. So in this regard, the vaccine rollout was very smooth. We did not see any, fighting at the level of CVC, and their monitoring was also inbuilt. And now we are rolling out, with the support of our expanded partner, quality assurance mechanism, that as we are rolling out more and more vaccines, are the SOPs for vaccine administration being adhered to, or are the people being offered 30 minutes wait while they are receiving certain vaccines for those individuals who are with comorbidities, and those who are a healthy individual, at least 15 minutes wait is being observed. So now we are strengthening our system with the quality assurance mechanisms in place. So I think I covered most of the points. So if any question I missed, can you remind me?
Okay, so thank you very much, Dr. Sophia. Unfortunately, we are gradually running out of time. So if you don't get to listen to your question today, don't worry. We are taking note, and we have another opportunity for another session next Saturday, 19th of June, 2021. And I see there's a lot that's been said in the chat, a lot of interaction. Please just take a look at the chat. And I would like to give the opportunity to two other people in the panel to get to say a word. So I'm going to invite Mohammed Imran. If you have a question, just quickly introduce yourself. Tell us about your involvement in COVID-19 vaccine introduction and ask your question. And then I'll turn towards Barka Tafida, Maman, team lead for Nigeria, for one last word before I hand over the floor for the closing remarks to our host of the day. So over to you, Mohammed Imran.
Thank you very much, Charlotte. Good evening, everyone, and the Pakistani team. I am Mohammed Imran, working with the Ministry of Health, Kaduna State. I'm directly involved with the COVID vaccination, implementation, community engagement, and of course, data management. I have series of questions outlined here but a number of it have been answered, so I'm going to be very brief.
So just tell us the burning question, burning question, please.
Yes, of course. I want to know how, the Pakistani team or vaccination team or the government intend to triangulate the data of health workers in the country alongside those that have been vaccinated, putting in mind that the hesitancy, non-compliance, or even rejection exist within their mind. Thank you.
Okay, so I don't know if Dr. Sophia, Mohammed Imran, or Dr. Kayani. So the question is around triangulation.
Let me start. It's a very good question. I really want to share with you this answer with statistics. So if you see per 1,000 COVID cases among healthcare workers, the positivity was at time 19, at times it was 34 way back in October, November last year, coming to 24 in December and 15 in January. So once in February, the vaccination, when it was actually started among healthcare workers as the first cohort, according to the risk category. So in February, when the vaccination coverage among healthcare workers was only 18%, the positivity dropped to 19%. And when in March, it was 36%, the vaccination coverage, the positivity dropped drastically to only 6%. And then likewise, when the vaccination coverage was increasing to 48%, 73%, and in June, 85%, the positivity is decreased to 5%. So you can well imagine how we have managed the data triangulation. And this story, the success story, has helped the other hesitant healthcare workers to get the vaccine. And now they are preferring at times Sinopharm vaccine because they have listened and read so many stories regarding AstraZeneca. So at times they love to get Sinopharm, who were basically reluctant at the beginning against the Sinopharm. So it is just interesting story, and the things are evolving, and Pakistan is doing wonderful with regards to healthcare workers vaccination, as they are doing with the rest of the risk groups. Over.
Thank you very much, Dr. Mohammed Imran Qureshi, and all the other members of the Pakistani country group. And just to, I'd like to turn towards Barka Tafida Maman, the team leader for the Nigerian Scholar Group. And just for if you are joining for the first time or you don't know what this is all about, these are alumni that is formed of the Geneva Learning Foundation Scholar Program, who came together because in the face of the wake of the COVID-19 pandemic, to put their heads together to see how to maintain immunization services during the pandemic, creating what we call the COVID-19 Peer Hub. And so with the introduction of the COVID-19 vaccine, I think it's but normal that these actors that were very active during with maintaining immunization services during the pandemic will be invited to champion the introduction of the COVID-19 vaccine. And so they're gathered here today from Nigeria, from Pakistan, and in solidarity to our Indian peers from India also to share experiences, lessons learned, and challenges around the COVID-19 vaccine introduction. So Dr. Tafida, your hand has been raised for a while now. Please go ahead and unmute yourself if you have a question, ask your question, and then your closing remarks at once. Afterwards, I'll turn over to Dr. Mohammed Imran Qureshi. So Tafida, over to you.
Oh, thank you very much, Charlotte. Once again, many thanks to the Pakistani team for that great presentation. I had two questions, but one has already been answered. I would like to know if there's been any challenges around the financing mechanism. If yes, what's the most critical and how was that addressed? Thank you.
Okay, thank you very much. I think Dr. Sophia, you'll be best placed to address that.
So there was some break. I think he's asking for financial challenges. Am I right?
Yes.
Okay.
Yes.
So yeah, because when we applied for COVAX, we were thinking that 20% of our population will be vaccinated from the COVAX, so we won't be requiring much of the finances for vaccine procurement. But then, all of a sudden, we came to know that no, COVAX is not coming to Pakistan very soon, and the supplier or the manufacturer has not been granted, emergency, import waiver. So in this regard, we were, challenged. But thank God that we had number of resources available within the country that were mobilized for immediately do bilateral procurements. And then, this time was supported by our Chinese friend who donated vaccines. So Sinopharm came as donation initially. And then this time was, we leveraged this time to do our procurement immediately. So in the beginning of the pandemic, the government has developed a pool funding for COVID-19 response. So from those funds, there were a lot of savings that we could easily mobilize for vaccine procurement. Although we had been also relying on certain donors for, for procurement of vaccine, and World Bank and Asian Development Bank have also come up for, they will be giving us loan. However, up till now, we have done all through the government resources. And along with this, we were also supported, through this SAS program that was already cash program that was to uplift the communities who are very poor in the society. So in this regard, that fund was also utilized upfront to build the economic situation of those who were below the poverty line. So in this regard, finances did not remain a challenge, but in future we are also relying on a few loans that are coming up for COVID-19 procurement or vaccine procurement also. Over.
Yeah, thank you very much.
I want to add in this question, Charlotte, quickly, just 2 lines. The government oversight and ownership to this initiative of COVID pandemic and vaccination response is really appreciable. And once government decides to do something, they have all the resources, vision and will, and the leadership, they can do wonders. And partners are always there to support as far as technical and financial support is concerned, if it is really required. So I have seen myself, our Prime Minister, our Minister for Health, our other ministers, our bureaucrats, our secretaries, they are always on their toes. They are always visiting mass vaccination centers and other COVID vaccination centers. And, once the highest leadership is there in the field and they are leading from the front, they leave no lacuna to make this campaign successful, because they believe unless we have vaccinated a specific cohort, we will not be able to develop the herd immunity, and our restrictions, our smart lockdowns will not open. And then we have the economic and social restrictions. So they believe vaccination can give us a gateway to open up the various sectors of life, and we can return to the normalization. That's why they have not only led from front, but they have secured enough funds to procure vaccines along with the COVAX facility, which is coming across. and they are also getting few of share from the China. So the situation is very much enabling within the country with regards to the funds regarding the COVID vaccination. Over.
Thank you very much, Mohammed Imran. And I see a comment from Chika in the chat that says the highest leadership leading from the front. Thank you, Chika. And thanks to you all for the wonderful comments you've been leaving in the chat. So before I finally give the final word to Dr. Mohammed Imran Qureshi, I'd like to turn to Reda, who is also a valuable guest in today's inter-country peer learning on COVID-19 vaccine introduction, to say a word. So Reda, you have been listening in carefully, and I've been seeing a few of your comments in the chat. So what do you have to say to the countries that are gathered here today, Pakistan, Nigeria, and India?
Thank you, Charlotte, and again, greetings, and really, you're very impressed by what I listened to today by Dr. Sophia Yunus's presentation. Thank you for sharing with this unique group of participants. I also noted that Barkata Fidamaman, you made a point of honoring our Indian colleagues, and actually I want to share with you, I received an email in response to the last reminder, and this is, I will not cite her name, but she wrote, unable to join today's event due to personal loss caused by severe COVID illness, despite despite all of our efforts. So this really underlines that we're talking about here is not a feel-good exercise. It's not a nice to have to be connecting practitioners from different countries, quite the opposite. And I want to, for those who may be joining for the first time or who do not know about the COVID Peer Hub, the people who are in the room are collaborated during six intensive months in the very early phase of the pandemic, from a group of more than 6,000 immunization practitioners who collaborated on the recovery of immunization services, how to keep vaccination going as the pandemic was disrupting services. They then collaborated to understand best practices in challenging hesitancy and growing vaccine confidence. And as early as November 2020, within the COVID-19 Peer Hub, practitioners had begun to do scenario planning for vaccine introduction, even before we knew which vaccines, what the vaccines would look like, what their profiles would be. And this was supported in 24 countries by voluntary country groups that really organized themselves with members from all system levels and parts of the country. So it is no accident today if many of the members of the COVID-19 Peer Hub across the different countries, including, I believe, both Nigeria and Pakistan, are involved in leading their country's response to this pandemic. Therefore, the significance of this inter-country exchange is also that participants within who are here already know each other, already know and trust each other. So you know that if you are hearing from a Pakistani colleague and you are in Nigeria, it is someone who, just like you, has put in intense effort in the COVID-19 Peer Hub, practicing, training, thinking, reflecting, applying critical thinking and problem solving in order to respond to the crisis, and then to think about how to build back better in the context of recovery. So to me, the significance of this inter-country exchange and the country exchanges that have preceded it is really at the heart of how, as a world, you're united together across, despite the many differences from one country to the next, despite the politicization of the pandemic, public health can grow stronger, significantly stronger from such exchanges, from the shared determination, and will, across system levels, across barriers of all kinds, across geographies and countries, in order to beat back this pandemic and build back better to be ready for the next one. So I'm quite impressed. I think that today was quite a powerful moment, not only about just in a way, enjoying sharing with other practitioners, but actually figuring out how we can continue to make a difference by collaborating in these new ways together. Thank you, Charlotte. And then once again, thank you to both the team leaders and to the other practitioners in the room, and of course, especially to Dr. Yunus for her presentation. Thank you.
Thank you so much, Reda. And just to say, if you want some more, be sure to join us next Saturday at the same time. And we do hope that by that time, we'll be able to broadcast the event live so that all those who are unable to join today will also be able to follow. So I'll turn towards you, Dr. Mohammed Imran Qureshi, for your final and closing remarks for today. So you close.
Thank you very much. Thank you very much. First of all, I will start paying highest gratitude and regards to the Geneva Learning Foundation, the core team, Reda Sadeki and Charlotte Embu, for your wonderful, wonderful efforts bringing this initiative at the forefront, and a lot of unsung heroes in your team. So I want to acknowledge each and everyone. Then I really want to pay my highest regards to the Nigerian colleagues who are together coming for this wonderful lessons learned and experience sharing workshop. And thanks to Barka, my colleague, who is just like excellent in his expressions, and he is leading Nigerian team from the front, and Nigerian have set an example for others that strong scholars team can change the overall immunization system within the country. So we are really impressed from Nigerians and developing our own country scholar team to that level which they have already achieved. So congratulations to them in this regard. And then I really want to pay solidarity to Indian colleagues who are passing through a difficult time. We have highest feelings for them, being our neighbor, and we really wish for them that they could come up with this hard situation very early and peacefully and return back to the normal life. So I really want now regards and thanks to Dr. Sophia Yunus. I already said that she is just a wonderful lady and having tons of experience in the immunization program. She is a great gynecologist as well. So she is a very nice lady, nice always, and always very sportive. So she just came across and led this forum from the front. So thanks, Dr. Sophia Yunus, for all of your efforts. And now I want to appreciate all the scholars from Pakistan who are chipping in this exercise in one way or the other. They have contributing their experiences. They are sharing some data points, and they are like chipping in, giving few ideas to bring them together to put at one presentation and share their experience. So I want to name Dr. Kayani, Taimur Kayani, who is just doing wonderful. And I also want to appreciate Madam Rosina Mistry, who is just regularly bringing these scholars together every week. And we are doing wonderful together as one team. So a lot to say and a lot to discuss, but constraint of time, just we have to put a break. Today, we really want to have a live session, but due to technology, it wasn't possible. But I always believe we can do it at some another time, and this recording will be shared with a lot of people. I believe together we could end this pandemic through a successful vaccination drive, whether it is Pakistan, whether it is Nigeria, whether it is India or any other part of the country, any other part of the world. Lastly, as Reda already said, that scholars, probably they are now the strength within each and every country, because they have enlightened their vision with regards to immunization, and they are the potential people. Countries are using them together as the experienced bunch of scholars who are contributing in one way or the other with regards to COVID surveillance, with regards to COVID vaccination drive. There are a lot of people in our country, Dr. Samia, Dr. Rizwan, Kesser, who are always suggesting ideas and ways and means to uplift the morale and contributing in one way or the other. The NCOC led by the government has played a wonderful job in putting the break to this pandemic. And in Pakistan, I'm too glad that the normal modality is now coming, returning back because of good surveillance, contact tracing, and good vaccination drive within the country. So thank you, everyone. Wish you best of luck. and stay safe, stay blessed. Over.
Thank you very much, Mohammed. Thanks, everyone, once again. And there's been a request for Dr. Sophia's presentation, so I'm sure, Mohammed, you'll be able to make that available so we could share with the Nigerian peers. So once again, thanks, and have an excellent afternoon, evening, night, depending on where you're joining from. So once again, our hearts and our solidarity goes out to our Indian colleagues. We are behind you, and we honor the work you're doing daily to ensure that to fight against the pandemic and ensure that as many people as possible receive the much needed vaccine. So once again, bye for now.
Thank you very much. Pakistan Zindabad.